Hello guys, welcome to MEDVERSE, and today we are going to discuss a little bit complicated chapter of cardiology, aortic stenosis, right? So if I talk about aortic stenosis, you all know that if this is our heart, let us make it very easy. Let's assume this is the aorta. So we have an aortic valve here. All of you know that the aortic valve has three leaflets, three cusps. Okay, three cusps, you all know that, of same size. And this aortic valve is basically, you have to know that in normal condition it is closed like this. It is closed, right? And if it gets opened, then basically it slides like this. Okay, so this is an open condition of the aortic valve. We are talking about aortic stenosis, which is basically it is not closing properly, right? So I am talking of the condition in which it is not closing properly because it is stenosed, right? It is stenosed. So basically what happens is that we have, this is the left ventricle, let's say right atrium, right ventricle, left atrium, left ventricle, and this is the aorta. I am writing A. So there is a gradient between LV and A. Let's consider this as A, that is aorta. This is the aorta. And let's say this is our left ventricle, a part of left ventricle. So remember that aorta and left ventricle, in normal condition, the valve opens completely, right? The aortic valve in normal condition, it opens properly. So whenever there is a common channel, you can say there is a common channel, there is no pressure gradient, so I can write delta P is equal to 0. This is our normal condition. This is our normal condition. Okay, this will have implications in the pathogenesis of aortic stenosis. So pathogenesis, what it says, we have something called aortic sclerosis. If this is our aortic valve and here, let's say we have some sort of inflammation or calcification, or let's say ossification, something like that, okay, or deposition of calcium here, this is called as aortic sclerosis. If this aortic sclerosis is associated with delta P, which is a pressure gradient, which is also called as transvalvular gradient, it is called as aortic regurgitation. Aortic sclerosis, stenosis, right? Stenosis. Slip of tongue, aortic stenosis. So now you understood what is aortic stenosis. Aortic stenosis, this pressure gradient basically is consistent with aortic stenosis. If there is no pressure gradient, then it is just an inflammatory process with calcium deposition, with inflammation, with you can say lipoprotein deposition. Okay, this is aortic sclerosis only. So don't get confused. A person of aortic stenosis who is undergoing valve replacement, the treatment of not sclerosis, treatment of aortic stenosis is valve replacement, aortic valve replacement. Now modern indications are there also, which is TAVI. We'll discuss about TAVI. If the person is undergoing aortic valve replacement with aortic stenosis, please do a mandatory coronary angiogram. Coronary angio is a must. Why? Because we have to see the atherosclerotic changes, because most commonly it is associated with aortic sclerosis only. Okay, so if I talk about aortic stenosis, one-liners, most common cause is basically atherosclerotic changes. Aortic stenosis with atherosclerotic changes, right? But if it is asked the most common valvular disease, it is MR, that is mitral regurgitation. Okay, mitral regurgitation. What is a congenital cause of aortic stenosis? So congenitally aortic stenosis may be associated with BAV. What is BAV? BAV means the aortic valve, which is commonly tricuspid, has two cusps now. And this BAV is associated with a famous gene mutation, that is Notch1 defect, and autosomal dominant inheritance, right? So this is commonly seen in younger patients. Okay, so this is about a gross introduction of aortic stenosis. Now we'll move to a little bit more detail and we'll talk about our main topic, that is valvular aortic stenosis. Valvular aortic stenosis. If I talk about valvular aortic stenosis, we can classify it into mild degree, moderate degree, severe degree, and we have an entity called very severe. Okay, so talking about mild, basically what is the fact that whenever, let's say this is the heart, whenever we have an increased cardiac output, the heart tries to compensate. Whenever there is a decreased cardiac output also, the heart tries to compensate. Okay, increased cardiac output, heart tries to compensate. Decreased cardiac output, heart tries to compensate. Decreased cardiac output means insufficient blood which is going into the body, into the circulation. Due to insufficient blood, the heart will pump more, and to pump more it will undergo a pathological process of hypertrophy. So we have here aortic valve opens into left ventricle, right? So we have here something called as the walls will be inflamed like this concentrically. Heart will be inflamed like this concentrically, and this is called as left ventricular hypertrophy or left ventricular concentric hypertrophy. Okay. So hypertrophy will occur, due to which the cardiac output will be not increased. You can say cardiac output will be maintained. Due to this maintained cardiac output, the person will not have no symptoms in mild or moderate aortic stenosis. Okay, no symptoms. But what happens if it is severe? In severe, there will be symptoms. Okay, in severe, there will be a significant amount of hypertrophy. When compensatory mechanisms fails, there will be symptoms present. Okay, when compensatory mechanism fails, there will be symptoms present. So in severe, it is an implication for aortic valve replacement. We have to replace the aortic valve. Okay, in severe, we have a rule called as 44-1 rule, which you have to know. 44-1 rule states that 40 more than 40 mmHg delta P. What I am telling, delta P, transvalvular pressure gradient. Okay, I told you 4 is more than 4 meter per second peak velocity. Whenever delta P increase, the peak velocity across the valve will increase, and 1 is basically less than 1 centimeter square valve surface area. Less than 1 centimeter square valve surface area. Okay, so these are the things which you have to know. And now we'll move to the symptoms, the clinical features of aortic stenosis. Okay, so symptoms. The first symptom, let's understand, this was the compensatory mechanism. This was the compensation. Due to the significant left concentric hypertrophy, what problems will be there? Due to this, the muscles are hypertrophied. Okay, muscles are hypertrophied. So there will be more oxygen demand. Since the cardiac output is not able to be maintained, the circulation is low. And due to this low circulation and associated with atherosclerosis, I told you that atherosclerosis is associated with AS. This will lead to decreased coronary flow. The heart itself, the muscles of heart itself are not getting like you can say sufficient blood supply. Since the wall was first thin and the blood vessels were adequate, the capillary density was adequate. But now what has happened? Now the wall is very thick and the capillary density is still the same, right? So decrease capillary density with respect to wall thickness. This all will lead to a very important symptom which you might be guessing correctly from now, that is angina. We have read a lot and lots of angina. Okay, so these are the 3 causes which occurs in aortic stenosis which leads to angina. Okay, now what happens is that this CO is maintained. Just pay attention to this word, maintained. I am not telling that it is increased with activity. So we are in a fixed CO state. That means if you do activity, the CO will remain same. Normally in normal state, the CO increases with activity. But now in aortic stenosis, we are in a fixed CO state. That means there will be syncope present in this patients. Okay. Now the cavity size of heart is decreased. Look at this. There is a decrease in cavity size, which means that the left ventricular and diastolic volume will decrease. Whenever volume decreases, pressure increases. That means left ventricular and diastolic pressure will increase, which means that when the pressure increases, okay, when the ventricular pressure increases to this extent, the left atria pressure must increase, which means that the left atrial pressure must increase, and it is equal to pulmonary capillary venous pressure or pulmonary capillary wedge pressure. You can write PCWP will increase. Pulmonary capillary wedge pressure will increase because pulmonary capillaries are opening here. Okay. And this pulmonary capillary pressure is basically responsible for the third symptom, that is dyspnea. So we saw here three important symptoms, which is very easy to remember if you go logically. One was dyspnea, one is angina, one is syncope. Okay. So with this, we come to the end of the pathophysiology and the symptoms based on the pathophysiology. Okay. Remember some common, you can say, queries. Aortic stenosis has occurred. So ventricle has malformed, right? Ventricles have malformed. Ventricles are not working that properly with hypertrophy set in. So atria will contribute to majority of cardiac output. What happens if this atria is malfunctioned? Let's say there was a atrial fibrillation, AFib. If aortic stenosis combined with atrial fibrillation, it is 100% fatal. 100% fatal. No doubts in that. Okay. Now, let's say we have an old patient with hypertension. In hypertension, you have to understand that the atrial pressure is more because the blood vessels are constricted. Atrial pressure is more, obviously, which means that it will reflect in the aorta. The aortic pressure is more. We told that the delta P is basically the pressure difference between aorta and left ventricle. So when this aorta pressure increases, this delta P must fall. Are you able to understand? This delta P must fall, and this fall in delta P will basically you can say indicate that the atrial stenosis is not that severe, but it is not like that. So basically what I am telling to say that if a person comes with systemic hypertension, the symptoms of atrial stenosis, aortic stenosis, not atrial stenosis, are masked. So you have to control the BP actively. Okay. Done. Okay. Another scenario which I want you to know, a syndrome called as Hayes syndrome. Hayes syndrome is basically angiodysplasia of colon. Associated with atrial stenosis. Angiodysplasia means the abnormal dilatation of blood vessels in the colonic wall. Abnormal dilation of blood vessels in colonic wall, basically in the rectum and sigmoid region in colonic wall. So a person with, you can say, recurrent GI bleeds, right? Recurrent GI bleeds. You can think of this Hayes syndrome. Not that common, but you can. Okay. Now we'll look to the findings on examination. How the patient presents. First, in mild or moderate AS, we have normal pulse. But in severe AS, we have a slow rising pulse like this. And this type of pulse is called as pulsus tardus. In very severe, we have a slow rising pulse which doesn't reach its amplitude. This is called as pulsus parvus et tardus. Okay. Done? Okay. And about this is about the pulse. Okay. If I talk about BP, we have a narrow pulse pressure. Normally BP is not that significant, but the pulse pressure is narrow. If I talk about JVP is associated with the right heart. So JVP will be completely normal. Due to this aortic stenosis, the heart is basically displaced a bit outwards, right? Due to left ventricular hypertrophy, the heart is displaced a bit outwards, and this apex of the heart, basically, this is the apex, this is the base. I hope you know. And this is the base. So apex of the heart is basically displaced outwards. Okay, and this is called as heaving apex. Okay, so heaving apex is a characteristic. Now let's go to the most conceptual topic, or this aortic stenosis. I'm telling regurgitation again and again. That is heart sounds. Look, there is a reason for everything. You have to see the reason. Let's talk about S1. So we will see a ejection click. Ejection click will be heard in case of bicuspid aortic valve. What happens is that the ventricles will contract. When the ventricles contract, the stiff valve, the stenosed valve, will open suddenly. So they will produce a high-pitched sound just after S1, which is called as ejection click. Okay, so this is the reason for the ejection click in BAV. If I talk about S2, we have three conditions here, and all three have a reason. If I talk about a degenerative pathology associated with atherosclerosis, then we'll have a soft S2, because it is a degenerative pathology, right? it is you can say fainting. A fainting will occur. So it is just a degenerative pathology, soft S2. If associated with BAV, that is bicuspid aortic valve, the aortic valve here, it is compliant now. Okay, as BAV occurs in younger patients, it is very compliant. Okay, there is no problem with that. So the S2 will be loud S2. In case of severe AS, in case of severe AS, just look at this. This is important to understand. Since our cavity size is reduced significantly, it is taking more time to be filled. Okay, and it is taking longer time to eject blood as well. So this time is A2, so we'll have late A2 will be late. Okay, but pulmonary valve will close fast. This pulmonary valve, there is no defect, right? No defect. It will close fast. Normally what happens after aortic valve, pulmonary valve closes after aortic valve. This is normal condition. But here what is happening is that as this is taking very late due to very severe AS, the pulmonary valve is closing before the AS. That is P2 is occurring before A2. So sequence is P2 then A2, and this is called as a reverse split S2. So here we'll have reverse split S2. This is a very common question. Okay, then we discussed about S1, S2. Let's talk about S3. Talking about S3, we know that S3 is produced when there is less than normal filling of a hypertrophic non-compliant ventricle. So will S3 be heard? Obviously, S3 will be heard. Let's talk about S4, fourth heart sound. Fourth heart sound, basically we have conditions. We must have a healthy atria. We must have a non-stenosed AV valve. We must have non-dilated, non-compliant ventricle. So is S4 produced? Obviously all three conditions are satisfied. Okay, all three conditions are satisfied. So this was about heart sounds. If I talk about murmur, then there will be a mixed frequency murmur. Okay, mixed frequency murmur means there will be two things that will be there, two pitches, low pitch and high pitch. Low pitch component will radiate to the carotid, and over the carotid area we will feel a low pitch, but high pitch will be radiating to the apex, which is classically seen as the Gala-Warden phenomenon. Okay, so we'll have a mixed frequency harsh murmur. Let's talk about the other investigations, that is ECG and X-ray and echo. So talking about the ECG, so you must be, I am assuming that you must be having an idea of the ECG. We can discuss ECG in any other class, but ECG, just know that there is a straining pattern, that is ST depression is not much. ST depression is not much, but there is asymmetric T inversion. Asymmetric T inversion. Okay. If I talk about X-ray, then you will see dilated aortic arch. And what is the investigation of choice? Always investigation of choice will be echocardiography. Echo. Okay. So with this we come to the end of the diagnosis part. Now let's move to the treatment part of this aortic stenosis. Treatment. If I talk about the definitive treatment, the best treatment done using bioprosthetic valves is basically aortic valve replacement. It's the best treatment available. In which patient you have to do aortic valve replacement? This must be indicated in severe symptomatic AS. Severe symptomatic AS. This is indicated in severe asymptomatic AS, but with LV ejection fraction less than 50%, with gradient more than 60 mm, or peak flow more than 5 meter per second. These are or. Okay, this is the thing. Then we'll see that if your aortic stenosis is rapidly progressing, that is on echo, let's say the aortic stenosis is increasing. Okay, if we are indicated for any other surgery, any other procedures, and if your dobutamine stress test is positive, dobutamine stress test is positive. So these are the conditions in which aortic valve replacement is done. But problem is that patient must be fit. But in many cases, as it is associated with atherosclerosis, this is the problem. Patient will be an elderly. So in elderly patients, you can't do this. Due to this, we invented, or you can say made a medical innovation that is very commonly done nowadays as price is now reducing, that is the transcatheter aortic valve implant or replacement. Transcatheter aortic valve replacement or implant, that is TAVI or TAVR. This is a costly procedure, but this is very done in cases where AVR is, aortic valve replacement is contraindicated. With this, we come to the end of this module on aortic stenosis, and one page we summarized aortic stenosis in total, right? With this, let's meet in other lecture. Let's meet any other day with a new topic. That's all. Thank you.